Hello, and welcome to another ASSFN podcast. I'm Danika Paulo, PGY6 at Vanderbilt University.
I'm Tessa Harland. I'm a PGY4 at Albany Medical College.
I'm Robert Ziechmann. I'm a PGY5 at Temple University Hospital.
And today we are fortunate to have with us our guest speaker, Dr. Erika Petersen. She directs the section of functional and restorative neurosurgery at the University of Arkansas Medical Sciences Center. She is the first female to become professor of the Department of Neurosurgery at UAMS. And she recently published an article in JAMA Neurology about spinal cord stimulation for painful diabetic neuropathy. So that's going to be the topic of our discussion today. And Dr. Petersen, thank you for joining us.
Well, thank you so much for having me.
Excellent. So jumping right into the questions, can you give us a little bit of background about what inspired this randomized control trial comparing spinal cord stimulation to conventional medical therapy for painful diabetic neuropathy? And what evidence was available at that time to suggest that spinal cord stimulation may be a meaningful treatment for this indication?
Yeah, so when people think about spinal cord stimulation, they typically think about failed back surgery syndrome, or as we call it, post-laminectomy syndrome, or more recently, I tried to call it persistent spinal pain syndrome of various types. And while that's probably the most common reason that we as neurosurgeons see a patient for a spinal cord stimulator implant, there are certainly other neuropathic conditions that respond. And so some of the early indications were that neuropathic foot pain related to diabetes might respond. Some of those were patients who had failed back surgery syndrome who also had diabetic neuropathy. And it was one of those, hey, by the way, doc, my feet feel better too. It's not just my back and my hip pain that's better. And so, a good researcher, a good scientist should note those things in their experience and then start to figure out whether that's something that actually should be investigated. There was research using low-frequency spinal cord stimulation first. Some of the first studies in the spinal cord stimulation for painful diabetic neuropathy actually go all the way back to 1996, but then published specifically randomized controlled trials looking at the use of a low-frequency stimulator in about 2014, 2015. So we know that there was a benefit from a use of low-frequency spinal cord stimulation, but you can imagine that people who have painful dysesthesias, they have burning, pins and needles, tingling of their feet, or they describe this creepy, crawly ant feeling, how they might feel when you use a paresthesia-based form of spinal cord stimulation at low frequency. What we saw in some of those research studies is an attenuation of response and patient attrition associated with that. So when FDA approval came along for high-frequency spinal cord stimulation at 10 kilohertz, you now had efficacy for back and leg pain in a paresthesia-independent spinal cord stimulator. And anecdotally, some patients who said, my feet don't feel as bad. So a pilot study was done looking at painful polyneuropathies of all sorts. And in those patients, they showed that there was an improvement in terms of the neuropathy in the feet, particularly in the pain. But that pilot, interestingly, also looked at neurological function for the first time. And that most interesting part of that pilot, which is published by Galan and colleagues, is that the subset of patients who had diabetes-related painful neuropathy seemed to improve the most of all of those patients combined. And so that was enough of a signal to suggest that a large-scale randomized control study may be of benefit. And so that's where the Senza PDN study, of which I'm the principal investigator, came into being. And so we looked at then, can we show efficacy using 10 kilohertz paresthesia independent spinal cord stimulation in patients with painful diabetic neuropathy compared to what is the gold standard best conventional medical management, and show that there's an incremental or dramatic superiority of benefit compared to what patients would otherwise get for their best treatment.
Thank you, Dr. Petersen. That's really helpful to be able to hear sort of the background that led to the development of this trial, because it has been big news within the neuromodulation field. But for our listeners who aren't as familiar with the study, would you please give us a brief overview of your trial and subsequent outcomes?
Yeah, so we designed the study to be a randomized control study of 18 U.S. centers. We enrolled and randomized 216 patients. They were randomized 1-to-1 to either conventional medical management by itself or high frequency spinal cord stimulation plus conventional medical management. And then we looked at outcomes. We looked at pain scores, but we also looked at quality of life measures, including global assessments of function and EQ-5D, sleep scores, all of those elements as well, to see what differences were identified between the two randomized groups. We looked at that at 3 months, which was our primary endpoint, and we also looked at it at 6 months. In addition to looking at those pain-related measures, we also did standardized neurological exams. That included looking at motor function, reflexes, and sensation exam. And we used monofilament and pinprick testing at 10 different spots on each foot. That was standardized. And the reason why we used those examinations was because that is typically what's done for a limb preservation assessment. Patients who have preserved sensation on that level will have less risk of foot loss related to having a loss in sensation. And so those things were evaluated for patients, both the neurological assessment as well as their pain and quality of life measures. What we then did at 6 months is we allowed people in either group to choose if they were dissatisfied with the treatment benefit that they were getting to cross to the other group. Nobody in the 10 kilohertz spinal cord stimulation plus CMM group chose to cross to just CMN by itself. And about 73% of patients ended up crossing from CMN into the high frequency stimulation group. So when at the end of that, we ended the randomized component of the study and then went to a open follow-up patients who were implanted, and we followed everybody post-implant for 24 months to look at what those changes were in terms of pain and quality of life and neurological function, and how well were they maintained out over time. And so what we saw is, first of all, that only about 5% of patients who received conventional medical management alone versus 79% of patients who had a 10 kilohertz stimulator plus conventional medical management were deemed responders at 6 months. And we call a responder somebody who had at least a 50% reduction in pain. As you would expect, when somebody responds and has improvement in pain, their quality of life, sleep, and all those other measures were also improved. And it was about the same difference between the two groups. And interestingly, we did see neurological improvements in the group with the stimulators more than we saw, dramatically more than we saw in the conventional medical management group on its own. And so it became very interesting then to follow and see, after somebody had been implanted up to 24 months, what kind of durability there was. A lot of the issue I mentioned with low frequency stimulation is that attrition, that people stopped using the devices or they just weren't working as well over time. And so we published our 12-month findings in Mayo Clinical Proceedings in December of 2021, and we showed durability at 12 months across everything. And then we have presented our 24-month results, and we're working on the 24-month manuscript currently to show the durability of these results continues to 24 months.
Well, Dr. Petersen, I think you kind of addressed already. My next question was going to be results beyond the 6-month mark. I'm curious kind of what the plan would be in terms of how far out these results could be followed and what you would expect. It seems that based on what we know about neuromodulation in other areas, for example, like RNS or epilepsy, that we might expect continued improvement. What are your thoughts on how long you would follow these patients potentially?
Yeah, so at 24 months, the patients exited the research study because that was the design of the protocol and what they had consented to, but they are in my clinical practice at my center. So if they ever need anything, I see them and take care of them. And anecdotally, we know that patients have made it further out, but we haven't systematically followed them past 24 months to actually be able to say with statistical rigor what we could see in that area. This is where, ultimately, it'll be really exciting to see some real world data that can go longer once patients are able to get an implant, and we can track them longer term in, say, a prospective registry or a retrospective analysis. We may have a better sense of what the durability and sort of the real world outcomes are. And there's been a real emphasis in the spinal cord stimulator literature recently of being able to translate clinical trial results into real world practice as part of that. I would love to show what this looks like at 5 years, and we just didn't have a design that would do that. What we're showing with durability at 24 months is already what's best published that's out there. There's nothing that is really longer than that for this size of study in spinal cord stimulation at this time. And so more is always better, but there's a point at which we get stuck with asking people to volunteer their time participating in research as well.
Yeah, hopefully, with the improved programming and durability of this therapy, we'll see their benefits beyond the 24-month period. So to recap, the inclusion criteria for this study that were chosen were patients that had painful diabetic neuropathy for 1 year or more that was refractory to gabapentin and at least one other analgesic class of medications, lower limb pain with an intensity of 5 on the visual analog scale or greater, BMI of 45 or less, an HbA1c of 10 or less, daily morphine equivalents of 120 milligrams or less, and patients that are medically appropriate for the procedure. So can you please explain in more detail how you selected these inclusion criteria? And do you think that these criteria capture the clinical target for the PDN spinal cord stimulation population, or would some of these patients be otherwise not eligible for SCS?
Well, we tried to design a fairly pragmatic study. So, there's a lot of discussion about what's the optimal hemoglobin A1C in order for a patient who has diabetes to safely have surgery. And there's a lot of debate about whether that's a 8%, et cetera. We were pretty generous at saying 10% or less. And so that's a fairly permissive inclusion. Similarly, BMI of 45. So these are not necessarily the textbook dream surgical candidate for an implant. These are patients who we hope represent pragmatically what would come into a patient a patient waiting room in most offices throughout the US. It's important to talk about refractory to medications because we're still talking about an implanted device. While we think of spinal cord stimulator, particularly through a percutaneous approach, is a relatively minimally invasive procedure, it's still an implanted device that has some morbidity associated with it. And the risks compared to, say, the risk profile of side effects with taking medications may be a little bit more escalated. And so it's good to certainly let people have a trial of medication. The other thing is, if somebody's diagnosed with painful diabetic neuropathy, they're not necessarily going to arrive on the doorstep of an expert in neuromodulation immediately. And most of them will need some sort of medication or something to temporize their symptoms if it's not really going to help long term, while the referral process, the workup of candidacy for SCS, all of those things happen. And so somebody who's been diagnosed for PDN for a year, who's had a trial of medication, that the next step forward makes sense to go to SCS. So those are the reason that we set those inclusion criteria. I think that will cover a fairly large number of patients who qualify. And the biggest piece of that, I think, is educating clinicians who are caring for these patients to think about spinal cord stimulation as an option, which is something that is not very familiar to a lot of the family practice endocrinologists, others who help to manage patients with diabetes.
Now, it sounds like the inclusion criteria, as you mentioned, is very comprehensive at capturing the target population, that you had broad criteria on things like BMI, hemoglobin A1C. But did you find that there were any particular patient characteristics or clinical factors that seemed to predict better or worse outcomes with spinal cord stimulation, or the salience of those effects?
So we didn't really notice. We were hoping to see actually that there might have been some sort of correlation between BMI and an outcome, or vice versa, that you would think that somebody whose pain is better, maybe their BMI would improve with treatment, or maybe their A1C would improve because they didn't have a pain limitation to exercise. But we actually didn't see any change in those two. There didn't seem to be connected for the general average across the entire population. So I think that when you think about clinical factors for outcomes, the way that I select patients with painful diabetic neuropathy to have a stimulator as part of my clinical practice is the way I select patients to have a spinal cord stimulator for complex regional pain syndrome or for refractory back and leg pain. Is this somebody who has, who's motivated, who's engaged, who can run the technology, and seems to be a safe, appropriate candidate? And so I use that same criteria towards selecting outcomes in PDN as I would for other candidates for other conditions that I treat with SCS.
Appreciate that insight. Dr. Petersen, how would the patients describe their pain relief and impact on their lives? Maybe in a little more qualitative way, and from what you saw from the study, and what was their perception of the whole experience of going through that process?
Yeah, those are great questions, and I think it's really important that we as implanting surgeons think about what the patient experience is like. What we do is a little strange. I had a X-ray technologist who I worked with in the operating room who would always remind me that my job is creating cyborgs. And so I think it's important to remember that what we do is a little science fiction-y, and not everybody thinks about it in the same way that those of us who do the surgery routinely think of it as. What stands out though to me are the stories of how this impacts life. I have a patient who works as an electrician with a whole bunch of apprentices doing installations for commercial buildings. And he would have to point and delegate and try to teach what needed to be done on certain wiring because he couldn't feel the ladder under his feet. And with the stimulator working, his pain was such that he could work an entire day without having to take breaks. And so he didn't get that same kind of, eye roll from the team that he was working with. And he was able to get back up on the ladder again. And that makes him a better teacher, a better boss for the team as they're going through these large commercial construction projects. A patient who was so delighted that she could just put her sneakers on that she showed me a little dance step in the exam room, and she just was delighted that I'd seen her before wearing flip-flops and no other shoe would go on her feet because even just the pressure of the inner lining of the shoe was painful to her. And she came in wearing the cutest sneakers and wanted to make sure that I knew that these ones that she'd had her eye on for a while. And I think the most interesting case is a patient who was really limited by pain and not doing any kind of work outside the home, really disabled about things. And she went from trying to drive a school bus route as a substitute bus driver to volunteering to drive the fire truck for the volunteer fire department. And you think about the level of confidence to be able to take on those sorts of responsibilities, just to be able to walk down a soccer field to watch your kids play a game, to be able to sleep at night and not be irritable the following day. And all of those sorts of anecdotes are what keep us as functional neurosurgeons going. And we hear all those things. The goal of what we do in functional neurosurgery is to improve function, to improve quality of life. And so when patients are able to give you those snapshots on what it actually means to them to maintain their job, to maintain their connections to family, to sleep better, and how that translates into how they interact with the world and then contribute to their own way of making the world a better place, that's just an amazing gratification. So hopefully you'll get to hear some of those stories yourself.
Excellent. Yeah, that's a great reminder of why we do these therapies, and patient quality of life is always at the center. So it's great to hear those stories, and thank you for sharing. In the course of this study, were there any unexpected results that came up or patterns that emerged during your analysis of the data, and how did you handle those?
Yeah, so I mentioned the sensory changes and that we designed the study to look for neurological and sensory changes. We were hopeful we were going to see things, but it was one of those sort of, skeptical kind of hopes. And so as we started to have people telling us, no, I can feel my feet. No, I can, that's different. That was one of those things where if I weren't there hearing that, if I wasn't doing the foot exam myself, I don't know that I would have believed it as much. And so while we were optimistic that we were going to see what that original pilot had suggested, actually seeing that 60% of people had improvements neurologically and that they were maintained across every time point. And in fact, most interestingly, this definitely surprised me. We went from about 59% to about 62% of people with neurological improvements between 6 months and 24 months. Why would people who continue to have diabetes, I just told you that their A1Cs didn't really change. Why would people who have continuing underlying cause of their neuropathy have stable to improved neurological exams after 24 months? That is amazing to me. I would expect those people to be worse. I mean, they have an ongoing insult to their nervous system, right? And so that is the thing that really I think is the most striking about our findings. And, the device now, based on the JAMA Neurology publication and the data that we submitted to the FDA around that same time, the 6-month randomized data, is what led to FDA approval for treatment of pain related to painful diabetic neuropathy in the lower extremities. But the sensory findings and the fact that we're showing that maintenance of sensory and neurological improvement is probably the most unexpected piece of it. I would have thought that might continue to sort of hold a plateau that gently trended down over time. The fact that it's trending up is leading me to be really excited about trying to follow on and understand that even more.
Yeah, that's really interesting, and kind of reminds me a little bit what we were talking about earlier with other forms of neuromodulation, where typically with prolonged follow-up, you continue to see improvement in outcomes. So maybe that's something that could be the case with the sensory and neuro findings. But something that stood out to me as interesting was your wound complication rate of 5.6, which is consistent with spinal cord stimulation implantation for the general population, let alone patients with diabetes. And looking at your patient population, you quote that you had 60% of patients who had suboptimally controlled diabetes. Presumably, these patients would have historically required some sort of diabetes optimization prior to undergoing a surgical procedure. Did these numbers at all surprise you in the fact that you didn't have higher infection rates? And do you think that this offers grounds to maybe reconsider some of the strict A1C requirements that often exist for surgeries for other indications?
Well, to answer that last question first, I do think that a strict A1C cutoff without any flexibility to the clinical situation is probably missing the boat. A1C is a delay measure that is a proxy for glucose control over time, right? So more interesting is what you see, say, with continuous glucose monitoring in the perioperative period. So if you really want to talk about glucose optimization and how you're going to manage a patient in the perioperative window, A1C is a lagging indicator and it's going to delay. And I think really a case-by-case basis of what's the procedure, how small is the incision, has the patient had an history of infections and wound healing problems before? Do they have current sores or ulcers that you're concerned about? All of those things go into the calculus. So if a patient has an A1C of 9.5, but they've never had ulceration issues, they have a really reliable way of managing postoperative healing, then they may be actually a very decent surgical candidate. And so the other piece that goes into that is understanding sort of where you can be with tight glucose management that won't show up on an A1C. So I wouldn't put somebody off just because their A1C was close to 10. I think we've demonstrated that we have a patient population where less than 10 can be done safely. The other thing I'll say is that, I think it's important that patients are educated about what we as surgeons are worried about related to wound healing complications. We're worried about surgical site infections, and we're worried about wound healing. So in patients who have poor microvasculature and poor circulation, it's actually my bigger worry is wound healing. If they have slow delayed healing and then they have a super infection on top of that, then we're in a complicated situation. And so when I educate a patient about what to watch for, how my office is going to be available to them, how we're going to watch that wound together as it heals so that we can make sure that we stay on top of and optimize their healing process. I think there's a lot that can be done medically to help to support that patient and get them something that they will ultimately benefit with as part of managing the risk and return of each one of those patients' considerations. So I think ultimately it comes down to using clinical information to sort of prompt what your clinical decision-making process is, communicating really well with the patient about what possible complications there are and what the reservations are for their specific circumstance, which is part of our patient education and also informed consent discussion, but then having a really robust way of helping that patient to succeed. And if that means that they are going to help you by taking a photo of their scar and sending it to your office every couple of days, or whatever the system is to maintain that open channel of communication, then you find out what the right system is that helps you as the surgeon do well and helps that patient do well through the process together.
That sounds like a great process to get patients on board and on the same page. So kind of speaking of that, was there a process with a trial, these are all percutaneously, I believe you said, and did patients undergo trials before permanent implantation? And are there any specific settings that would be useful in programming for this indication versus other indications?
Yeah, so the way our protocol was designed is that this was a percutaneous device implant. So everyone had a percutaneous stimulation trial and went on to permanent implant only if they were successful responders during the temporary test trial with at least a pain reduction of 50%. And then our mix of investigators was some neurosurgeons, but a lot of interventional pain physicians. And so the standard approach was to do percutaneous permanent lead placement as well. As far as the implantation technique, we left that to the investigators at each of the 18 centers to use what they were considered their most successful approach. So at our center, we do our permanent implants asleep under general anesthesia. We use SSEP and EMG monitoring and testing as part of that. The Nevro device location, the 10 kilohertz for this is at T910 and down into the body of T10. And so is an anatomic, but I wanted to make sure that we at least had the neurophysiological midline identified and knew that we had right and left side covered using our intraoperative testing and monitoring. As far as the frequency settings and programming, the majority of these patients ended up programmed using the straight 10 kilohertz algorithm, which is at 30 microseconds and 10 kilohertz, finding a single bipole over the quote unquote sweet spot location, which majority was at T910 disc space or just that's over the body of T10. There are a small number of patients who used some of the expanded programming options that are available within the Nevro device, including frequency pairing. And some people who even tried some low frequency options, but the majority of patients still were using a fairly straightforward 10 kilohertz protocol.
Excellent. And in regard to clinical implementation of the findings of this study, where are we in the process of spinal cord stimulation becoming a more accessible treatment option for patients with refractory painful diabetic neuropathy?
Yeah, so there's three things that we need in order to get patients access. You need FDA approval unless you're going to do the procedure off-label. You need insurance to reimburse so that the patient doesn't have to pay cash. And you need to have patients who are aware that this is an option for them. So FDA approval was granted in the summer of 2021, specifically for high frequency spinal cord stimulation at 10 kilohertz for the pain related to diabetic neuropathy in the lower extremities. Subsequently, PDN treatment using spinal cord stimulation at low frequency has also been added to the labeling for both Medtronic low frequency as well as most recently for Abbott at low frequency. It's important to note that that does not include the newer burst waveforms or diffusion tensor the DTM. The glial cell-based DTM waveforms that are available on those generators. Those have not been studied, and there's no published RCTs for those waveforms. I'm hoping that we're going to see and learn a lot more, but right now the most robust data for a paresthesia-independent form of stimulation remains 10 kilohertz. In addition to that, we've seen a couple of other things. One is the American Diabetes Association released a compendium recommendation of the treatment of painful diabetic neuropathy in January of 2022. This is an updated statement to the guidelines that were published in 2017, and they list, in addition to pharmacological measures, the use of a 10 kilohertz spinal cord stimulator to address painful diabetic neuropathy. So that is a very big deal to us as functional neurosurgeons, because it means that those that follow the ADA guidelines and recommendations should have awareness now through that compendium that this is an approved option based on the level of evidence that is available coming through the ADA. Additionally, the American Society Association for Clinical Endocrinology, the AACE, has similarly listed 10 kilohertz spinal cord stimulation as an option to treat PDN. And with additional data hopefully coming out, we're going to see more robust guidelines and additional evidence to support. What that is useful for is for insurance reimbursement. We have seen a good number of payers, both for-profit payers, which started with United, but we've also seen Aetna, Cigna, and other commercial health insurance companies include coverage for PDN using high frequency stimulation. So that means our patients are insured to have a SCS implant for PDN. And then the other thing that we've seen is that as the discussion is there, more clinicians are becoming aware of spinal cord stimulation as an option to treat refractory PDN. And that hopefully translates to relationships in our own communities where those of us who treat using neuromodulation build those connections to those who have these patients who have refractory PDN. And that then leads to an open conversation about how we can help with referrals of those patients and offer them the spinal cord stimulation trials and hopefully permanent implants for those that are successful in order to make an impact for some of these patients who are really affected by severe pain.
And Dr. Petersen, you touched on kind of the next question that I have was, as clinicians, how we can help to build this referral infrastructure and how to spread the word about this as a treatment option. I'm curious, in your experience, now that we're starting to see, insurance approval, the ADA listing this as an approved treatment, from your end, are you starting to see more and more patients being referred for this indication?
Yes. So we're starting to see more patients being referred. We're starting to see more conversation. And part of that has to do with, I haven't just been presenting our findings at neuromodulation and pain meetings, but I've been presenting at neurology and diabetology meetings and in other settings, even at podiatry meetings, because those are parts of the care team for these patients. And we want all clinicians who have input into the longer term outcomes for patients with diabetes to have as good information as they can for how to help those patients. I think that it will end up being twofold. Part of it is it really is geographically dependent, and a clinician can look around in their community and figure out who are the clinicians who seem to know and take care of patients with diabetes. It might be that the patients with diabetes go to a couple of prominent podiatrists, and they're the ones that are doing diabetic foot health checks, and that the partnership between the functional neurosurgeon and the podiatrist is the most important way to help to make that connection so that patients become more aware that this is an avenue to pursue. It may be in endocrinology and diabetology, it may be in neurology, or even in primary care. And I think the other people to recognize and who cares for people with diabetes are the diabetes educators. And so understanding what the experience of someone with diabetes is, where they get their healthcare from, what kinds of players are in that healthcare delivery team for them is different from community to community, and that will change how we as functional neurosurgeons help to build that referral network. The other part of it is a lot of these patients may be those who are hearing about this from others, and it may be word of mouth, and it may be something that is coming from the patients themselves. And so we see a lot of things now that are direct to patient information. And so who knows, it may be that that's a way that some patients discover this as well. And so I think, again, any person who's interested in treating patients with diabetes for PDN in their practice needs to think about what works best in their own community in order to really figure out how to spread the word effectively.
On the flip side, what would you see as being barriers to patients getting spinal cord stimulators for painful diabetic neuropathy, and what can kind of be done on leaflet level clinicians to kind of remove those barriers for patients?
Well, so I think there's a couple of things. One just has to do with access. There are 88 million people in the US who are pre-diabetic. There are about 35 million patients with diabetes in the US. And if you think through that population, about 25% or so have diabetic neuropathy. So about 5 million, 3 to 5 million have painful diabetic neuropathy. There's not enough people trained in doing spinal cord stimulator implants to help 3 to 5 million people. And so ultimately, it's not the right solution for every patient. And some of the patients who are most motivated will be the ones who are able to navigate that process. But that's where us as clinicians who do functional neurosurgery, having an awareness and having an openness to these patients to sort of promote that will help with the access part of it. The other pieces related to adoption have to do with the fact that when somebody with diabetes is seen by their primary care clinician, they are not just talking about pain, they are talking about every other system, and it's a holistic medical exam. They need to think about their eye health, their kidney health, everything else. And so the pain conversation may not come up every time, even though that might be something that ranks high in the patient's priorities. And so that's, again, where the conversations about the opportunities and where we can help may help to partner with other clinicians who are seeing these patients to help them realize that where there are other places where we may not be able to make a huge impact or inroads in terms of somebody's health, this is somewhere where we may be able to, again, take someone who sleeps 90 minutes at a time and get them 8 hours interrupted, and what that translates to in terms of cognitive, mood, and overall well-being improvements is a huge impact. And so when we can try to find those opportunities and think about it on a person-to-person level, how we're going to change one patient with diabetes at a time from having the disruption of sleep, then that becomes a easier to tackle issue than thinking about the global millions of patients that we otherwise would like to help. So we start small and see it scale.
Absolutely, Dr. Petersen. Those are great points. And thank you so much again for your time and joining us and describing this study and the implications of it, as well as just doing this really meaningful work that has such an impact on patients' lives. Is there anything that you want to leave our listeners with? Any final thoughts?
I just want to thank you so much for shining us light on this. I think if you'd asked me to predict that something that I was going to spend a lot of my research time on when I was a resident was diabetic neuropathy as a neurosurgeon, I would have scoffed. There's no way. How does a neurosurgeon end up talking about diabetic neuropathy? And so one of the things that I would suggest to those that are interested in functional neurosurgery is to leave room to ask that question. You never know what will happen when you start observing small things, and it may not seem feasible. It may not seem like a logical jump based on what your overall plan for how you want to grow your career or anything like that is, but it may end up being a place where you can really make an impact. And sometimes it's the quietest little whisper of suggestion that ends up turning into something that I hope is going to have a really big impact for patients. And I can't wait for somebody else to be on a journey like that. There's so many opportunities within functional neurosurgery to do it.
Thank you. That's really inspiring. Well, thank you to all of our listeners, and please join us for our next episode. Take care.